Okay, babies, now we're on our chest tubes, which, as you know, is big. Therefore, I got to the point where I just typed it out because I thought, you know what, I'm sick of it. I want them to know so many things that I'm just going to type it out. So if you have your chest tube handout, it was me. I did this. This is my writing here. And it's so much. It's so much. This is my copy. A lot more, right? Yeah, a lot of red. Okay, so when you look at chest tubes, remember RN only. And I put that at the top of my handout. RN only. When it comes to chest tubes, they are used to create a negative pressure. They treat a pneumothorax. We use them for patients that have a pleural effusion. Hemothorax. So gunshot wounds, stab wounds, penetrating wounds, ice pick for your ex who cheated. I'm sorry, I don't know where that came from. I have no idea where that came from. So hemothorax, pneumothorax, pleural effusions. Those are the most common things we're going to use a chest tube for. Now, your job, nurses, with anybody with a chest tube, cough and deep breathe, position changes frequently. Cough and deep breathe, position changes frequently. Big priorities. Cough and deep breathe, position changes frequently. Okay, so let's talk shop. First of all, you have to just listen. It's real quick, but you just have to listen. Okay, you have two chambers here. You have a suction chamber and you have a water seal chamber. They are worlds apart. The suction chamber is on the wall, like any other suction chamber. Suction chamber's on the wall. You need to have continuous, gentle bubbles in that chamber. So if you play it all the way out, your patient came upstairs from the OR, PACU really, recovery, and you are the nurse receiving the patient. Now, Sadie came in here and talked to y'all. She told you her patients have 5 chest tubes. So her surgeons, she works in the #1 place in the world on a cardiothoracic ICU. It's #1 in the world. That unit is known all over the world. She can't be dumb. So Sadie's patients get 4 and 5 chest tubes when they come to her. And she was a new grad. She failed her test 3 times and walked into that unit and now is a charge nurse. She was just sitting in that seat less than a year ago. So don't let failure worry you, because that don't mean shit. Now, she took them chest tubes. She's got to be smart. She's got to hook them up. As soon as the patient comes up, she expects a little bit of blood when she hooks them up. Because in transport, that's what you're going to see. You transporting them from one place to the next. It's a little bit of, kind of like trying for the patient, right? It's a little traumatic to move a person. So that's okay. When you first hook them up, it's okay. After that, no more red, free flowing blood. I wrote it on there. It says it on there. It says red, free flowing drainage is a hemorrhage. Highlight it. Red, free flowing drainage is a hemorrhage. Put note to self. You shouldn't have red, free flowing drainage from any tube, whether it's a Foley, a T-tube, a chest tube, an endotracheal tube, an NG tube. I don't really give a shit what it is. Foley tube. You shouldn't be having red free flowing nothing. So that's a big deal. Okay? Now, so the suction chamber, as I wrote on your page, must have continuous gentle bubbles. What if it's vigorous? The suction too high. Y'all done seen it yourself. It's loud, it's vigorous. Okay, turn the suction down a little bit. Just turn it down a little bit. Okay, so you're doing too much. So you kind of had to know that. You have to add water as needed. No biggie there. You just add a little water as you need it. And then we have the water seal chamber. When it comes to the water seal chamber, under the words intermittent, fluctuating, periodic, blah, 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 make sure you write this real big. The water seal chamber is all about titling. You have to write that word really big. It's all about titling. Now, just listen. Pay attention. Here we go. You are 3 years old. Your cousin is 4 years old. Your mother has bought bubbles, and his mother ain't got no money, so she used dishwashing liquid. Y'all still with me? You know bubbles are the most funnest thing for kids to blow. They can be entertained for hours blowing bubbles. So there you are at 3 with your favorite cousin who's a bit of a bragger. And he's over your house and you're blowing bubbles. Watch this. You take the wand out of the bubbles. And how did you get bubbles again? Did you inhale or exhale? Oh, okay. That's what I wrote. Bubbles are on exhale. You better know that. Bubbles are going to occur with exhale. Okay. Go back to the cousins. Remember, your older cousin is a bragger. So this particular weekend with his dishwashing liquid self, he comes and says, I can blow bigger bubbles than you can. Every time you blow bubbles, all you get is a bunch of tiny little bubbles. I can blow a really, really, really big bubble. And you're like, well, how do you do that? So he takes the wand out of the bubbles and he proceeds to blow a really big bubble. Think back. How did he get that really big bubble? Did he do this? Or did he do this? Which one? The second one. He got the big bubble by blowing shallow, slow breaths. Excuse me, is your patient supposed to be breathing shallow, slow breaths? Oh, okay. So look what I wrote. Large, fluctuating bubbles under problem is not good. We're not blowing dishwashing liquid. This is a patient. Large, fluctuating bubbles is not good. Here's what you need to make sure you know. That's atelectasis. That means your patient has atelectasis because they're breathing slower and they're breathing shallow. That's not allowed. So what did we say you got to do? You got to have this patient cough and deep breathe. It's common sense. Cough and deep breathe. Now, so we got a couple of rules. Whatever's going on with the bubbles, it cannot be continuous. Because does your patient continuously exhale? Hell no, unless they're dead. So you don't want this patient to continuously have bubbles because I just told you bubbles are only on exhale. Now, Tidaling. Let's do Tidaling. Here we go. Go back to California or go there for the first time. Here we go. When you're doing waves, tidal waves, common sense. Tidaling rises with what? Inhale. And falls with exhale. Don't that make sense? You're going to really see that when you sit at your test. You see the students come in here and say, I heard her in my ear. And we call it schizophrenia. And they be thinking about all this shit I be doing. This shit works. Tidal. That's what the patient's going to do. And you're going to see it. It's really cool. I know it's hard because, I don't know, in my clinicals, I never got a chest tube. I wanted one, but I never got one. Did anybody get one? Does anybody work with one? Thank God. You'll be okay. So when you don't do it, you got to YouTube it, right? I didn't have YouTube in the 80s. You do. Get the freaking YouTube and look at it. Know what it looks like. Because in real world, you ain't got nobody telling you, oh, girl, this ain't right. Okay, so you got to know. Okay? Now, here we go. So far, so good. Let's do drainage. Drainage is not a lot. Plus, you have to use critical thinking to remember why do we have any drainage at all. So let's think about this. If my patient had a motor vehicle accident with an airbag and your patient had a thoracotomy, which one would have more drainage? Yeah, I cut you. Wouldn't you have more drainage if I cut you versus an airbag hit you? In other words, what did the patient have done? Did the patient have a cabbage where you saw through her sternum and cracked her ribs and surgically operated on her? Well, guess what? She gonna have some drainage. But an airbag was just that, an air bag. So the drainage is not going to be tremendous, right? So you do have to kind of use your brain. But the overall bottom line is you're not going to have a lot no matter what. So how much do we have? 50 to 75 cc's an hour. You better know that. I bet you better know that. That's real. Here's the good thing. It's better to have less drainage than it is to have more drainage. In other words, beloved, you not really depressing me if I walk in the room and you're my patient and it's day 3 and you have no drainage. That's not depressing me. Because look what I wrote down at the bottom. By the 3rd day, what's okay? No drainage. By the 3rd day, no drainage is absolutely okay. And if you'll remember, the 3rd day is important. And I taught you when you take this test, look at all numbers. Look and see if it said 20 minutes, 3 days, 2 hours, 4 hours. If it says 3rd day associated with a chest tube, they're trying to tell you something. The lungs have healed. The lungs take about 3 to 4 days and then they heal. So if you don't have any drainage, oh, okay, it's healed. It's probably time to come out. Right in that same area, no bubbling is okay too. No bubbling on the 3rd day, absolutely okay. We have a rule about cloudy drainage. What is it? Infection. Our rule is if it comes out of the body cloudy, it's infected. If it comes up from pharmacy cloudy, it's contaminated unless it's propofol or something like a crystallized mannitol or NPH. Okay, so you know that. So cloudy drainage is infected. Now, the bottom is not as important as the top that I just gave you, but I want to give you a little bit of information about when it comes out. When this chest tube, well, first of all, let me backtrack. When When we insert a chest tube, it's extremely painful. When we take one out, it's extremely painful. It hurts worse going in than it does coming out. So you got to pre-medicate this patient for both. You never clamp a chest tube routinely unless you're checking for a leak. I'm going to say that again. Never clamp a chest tube unless you're checking for a leak. Only the physician removes it. And if I'm really honest with you, you're going to be the one that determines when it should be. So you better know a list or like a select all on when the patient's ready to have their chest tube removed. So here we go. Removal happens if there's less than 200 cc's in 24 hours. .99% of chest tubes are removed by day 7. So if you day 8 with a chest tube, that's a problem. Chest tubes need to come out usually by day 7. Chest tubes come out when there's no more bubbling or drainage and the lungs have healed. Chest tubes come out when originally there was some bleeding and then it turned serosanguinous and now it's more pretty much serous or pink drainage. So the changes in the colors, red to dark red to pink, is getting better. Chest tubes come out when the patient has no respiratory distress, as evidenced by respiratory rate less than 24. Respiratory rate less than 24, no distress, chest tube probably can come out. With the bubbling issue, trying to figure out if it can come out, you have the patient cough or you have them exhale. If there's no bubbles, it's time to come out. So I'm going to say that again. No bubbles on exhale or no bubbles on a cough, it's time to come out. Okay, last thing, you can put it at the top if you want. I don't care, at the bottom, I don't care, wherever you got space. This is the last thing, we're done with this. If it becomes disconnected from the canister, you put that part of the tubing in sterile water. And that has happened. If it becomes disconnected from the canister, then you put the end in sterile water. Remember, we never empty this part. The only way we never empty the chest tube itself. The only thing we do with chest tubes every shift is we take our black Sharpie marker and we go up to the chest tube container, we make a mark, we put the date, time, and initials. That's how you monitor the drainage amount. But we don't empty this thing. That's not going to happen. We don't empty it. So that's because if you emptied it, you just created an open system. So if it came disconnected, you better put that thing in water because you can't have no open system. Just like we said, put that end in sterile water. Okay? Now, what do we do if the canister fills up completely? Well, we clamp it. And then we go get another canister and then connect it. But that's not something the aide is doing. Aides don't do that. So you go get another canister, clamp the tubing before you change out the full canister for a new empty one. Last thing, If it comes, and remember where it is, well, it could be anywhere, but a lot of them typically are right in here or right in here. But like Sadie said, hers be having them all over the place because she's got, the best. Okay, so this chest tube, we're going to pretend it's right here. Okay, pretend like it's right here. It came disconnected. Shit happens all the time. I swear to God it does. If it does, you have to put a Vaseline occlusive dressing and leave just a little bit of it open. But most of it is covered with the Vaseline occlusive dressing. If it becomes disconnected from the patient, you need a Vaseline occlusive dressing with a little tiny opening left for air to escape. When we take it out for good, we use a Vaseline occlusive dressing to cover the whole thing. When we take out the chest tube for good, we use a Vaseline occlusive dressing to cover the entire thing. So you can see why I want you to read this again before you go take a test. Okay. Oh, thank you, baby. Put this word down. I put it down on my page. Thank you, sweetie. This is a word that you might see. Turbid drainage. Is that good or bad? Bad. That's cloudy. That's important. Turbid drainage. That's cloudy. That's why you have to know your vocabulary.